Welcome to the debate. Today, we're confronting one of the most brutal biological lotteries a human being can face, epidermolysis bullosa, or EB. We're looking at a group of rare genetic disorders where the skin just lacks the necessary structural proteins to hold itself together. It's a condition defined by fragility, where, the slightest friction can cause blistering, tearing, and lifelong pain.
Yeah, and it's often poeticized in the media as butterfly skin, the idea being that the skin is as fragile as a butterfly's wing. But that poetry, I think, obscures a clinical reality that is far more horrific. I mean, we're talking about skin that shears off at the seams of clothing, blisters from a simple hug, or tears when a child rolls over in bed. It's a relentless, systemic assault on the body's primary barrier.
And that really brings us to the central question we're debating today. For decades, the standard of care for EB has been, nothing more than advanced bandaging, essentially wrapping patients in cotton wool, managing infections, and hoping for the best. But I'm arguing that the landscape is undergoing a revolutionary shift. We are no longer just watching the disease progress. Between, the identification of novel genetic markers, the real-world success of bioactive topicals like Oleogel SN, and the horizon of 3D bioprinting, we are finally moving from palliative care to functional restoration.
And I'm here to argue that revolution is a dangerous word to use prematurely. When I look at the data, specifically the recurrence rates and surgical interventions and the logistical chasms we still face in bioprinting, I see that we're still just refining the bandages. We're getting better at managing the decline, certainly, but we're failing to address the root biological defect. So we're celebrating maintenance therapies when the goal must be a cure. We just can't confuse a better crutch for a repaired leg.
You call it a crutch, but I call it precision. Let's start with the foundation of any cure. Understanding the target. We have to look at the precision we now have in diagnostics. A recent study on Chinese patients with epidermolysis bullosa simplex, the localized form, didn't just diagnose them with EB. It used next-generation sequencing to pinpoint novel variants in the KRT5 gene. I mean, we're identifying specific amino acid substitutions like the PIL467FE and PR471-HIS.
I've read the study.
It's technically impressive?
Sure.
It is more than impressive. It is the prerequisite for any future intervention. Knowing exactly where the keratin filament structure is failing, down to the molecular domain, specifically the 2B domain of exon 7, that is what allows us to even talk about gene editing or targeted therapy. We're moving from a descriptive diagnosis to a molecular one. That's power.
But is it power for the patient or just for the pathologist? I want to push back on the clinical utility of that precision right now. You mentioned the KRT5 variants, specifically the C1399AT and C1412GA mutations. Scientifically, yes, it is the triumph of sequencing. But clinically, in that very same study, what was the actual treatment plan for those patients after they got this high-tech diagnosis?
Well, the treatment was standard of care, but that doesn't negate the diagnostic value.
The treatment was antibiotics for infection and botulinum toxin to stop sweating. That's 20th century medicine applied to a 21st century diagnosis. We become high-definition diagnosticians, but we remain low-definition therapists. The patient walks out of the clinic knowing exactly which amino acid is out of place, but they're still handed a script for an antibiotic and told to avoid friction. So identifying the mutation confirms the tragedy. It doesn't stop it.
You're dismissing the bridge because we haven't reached the destination yet. You can't gene edit what you haven't mapped. But let's talk about the low-definition therapy you mentioned, because I strongly disagree that our current treatments are stagnant. I want to look closely at the data on Oleogel S10. This is a birch triterpene formulation, birch bark extract, that has shown profound results in a case series out of Colombia involving patients with dystrophic EB.
Okay, I have reviewed the Colombian series. It's a retrospective analysis of 13 patients over 2 years. It's a very small cohort, even for a rare disease.
Small, perhaps, but the results were clinically profound, and we need to dig into the numbers to understand why. The study tracked the BSAP, the body surface area percentage of wounds. At the start of the study, these patients had, on average, 27.3% of their bodies covered in open wounds. I mean, just pause and imagine that. Imagine living with nearly a third of your skin compromised, open to the air, and weeping.
It is a devastating baseline, I agree.
After 24 months of treatment with Oleogel S10, that number dropped to 10.4%. That is a massive reduction in open wound burden. That isn't just a statistic. That represents significantly less surface area that needs to be scrubbed, dressed, and protected every single day.
The reduction is statistically significant, I won't deny that. A drop from 27% to 10% is measurable. But we have to look at how that reduction is achieved and the cost to the patient's daily routine. This isn't a pill you swallow, it's a gel. And the study explicitly notes that for 2 patients, the wounds actually worsened because the gauze adhered to the gel. In the world of EB, gauze adherence is a sterile way of saying ripping the skin off when you change the bandage.
Look, those were isolated cases in a difficult cohort, likely due to application technique. The broader trend was undeniable. Look at the EBDSI scores, the epidermolysis bullosa disease activity and scarring index. The skin activity score dropped by over 16 points. This metric tracks blistering, erythema, the redness, and erosion. A 16-point drop means a child is in significantly less pain. And the study quantified the human impact. 53.8% of the patients reported improved self-esteem and better sleep. When you're in constant pain, sleep is the first thing to go. Getting it back is a physiological victory that fuels healing.
I'm not saying the gel is useless. I am saying it's burdensome. And we shouldn't gloss over that. The same study highlights a major practical flaw, the residue. The birch bark extract leaves a whitish buildup on the wound bed. To get the drug to work effectively, you have to clean that residue off between applications. Now think about the mechanics of that. You're asking a caregiver to scrub the wound of a child whose skin shears off at the slightest touch. The study admits this adds complexity to an already excruciating care routine. So you're trading one burden for another, smaller wounds perhaps, but a harder process to manage them.
It is a trade-off, certainly, but the data suggests the net result is overwhelmingly positive. The frequency of dressing changes dropped. Do you know what a dressing change involves for an EB patient? It's not slapping on a Band-Aid. It can take 3 to 4 hours. It involves lancing blisters, wrapping every individual digit, applying layers of protection. If Oleogel S10 reduces the frequency of that ordeal, even with the residue issue, it is a win. The physicians perceived faster reepithelialization. The skin grew back faster. That lets these patients go to school, to interact socially. That is functional restoration.
But is it? Is it functional restoration or is it just a better lullaby? I have to bring up the mortality data from that same 24-month period in the Columbia study. 2 patients died.
The study deemed those deaths unrelated to the treatment. It's unfair to pin that on the gel. Correct. They were unrelated to the gel, but they were directly related to the disease. One died of sepsis, the other of severe anemia. This happened during treatment interruptions. This proves my core thesis. Oleogel S10 treats the symptom, the wound, but it does absolutely nothing to stabilize the systemic fragility of the patient. The moment access is interrupted or the immune system is overwhelmed, the biological reality of EB takes over. It's a topical success that masks a systemic failure. The revolution you speak of didn't save those 2 patients.
Masking a failure is incredibly cynical. We're modulating inflammation and stimulating keratinocyte differentiation. That is active therapy. But if you want to talk about systemic failure versus structural repair, we have to talk about the hands. We have to talk about pseudosyndactyly.
Mitten hand, exactly. In dystrophic EB, particularly the recessive form, the scarring is so aggressive that the fingers fuse together. The hand becomes encased in a cocoon of scar tissue, rendering it useless. This is one of the most debilitating, isolating aspects of the disease.
It is the visible symbol of the disease's cruelty, taking away a child's ability to touch the world.
But we're fighting back, and the data is strong. A 20-year study on the management of hand deformities has refined a surgical protocol that is changing the trajectory for these kids. The technique involves degloving the hand, carefully separating the fused skin envelope, and using K-wire fixation to straighten the digits. The results are measured using the DASH score, disabilities of the arm, shoulder, and hand.
It's a standard metric, but numbers can hide the experience.
What did the scores actually show?
Or was 90.2%. Let's define that. That is near total dependency. You can't feed yourself, you can't wash yourself, you can't pull up a zipper. You're effectively an amputee with hands present but bound. Postoperatively, that score dropped to 46.7%. That is a monumental shift in autonomy. That's the difference between being fed by a caregiver and holding a spoon yourself. That is the difference between watching other kids play and joining in. The study emphasizes that regaining these basic activities of daily living justifies the procedure.
You say justifies the procedure. Let's unpack what the procedure entails. You use the word degloving. We're literally flaying the hand to separate the fingers, peeling back the scar tissue, and then pinning the raw digits with wires to keep them straight while they heal. It's traumatic. It is painful. And the elephant in the room, the data point you haven't mentioned yet, is recurrence.
Recurrence is a challenge, yes. The disease is relentless.
It's not just a challenge, it's an inevitability. The average time to recurrence in that study was 22.6 months, less than 2 years. The reoperation rate was 1.72 procedures per patient. We are putting these children through a cycle of agonizing surgery and rehabilitation, only to watch the scar tissue creep back and fuse the fingers again within 2 years. It's Sisyphean. We're rolling the rock up the hill, watching it roll down, and calling it a success because the rock stayed at the top for a few months.
But for those 2 years, the child has hands. You cannot undervalue 22 months of holding a toy or using a tablet or hugging a parent with open fingers. That is not a few months. That's a massive portion of a childhood. The study showed that pain scores drop significantly after the initial healing. The improvement in the DASH score suggests that despite the looming recurrence, the patients and families value the intervention. They keep coming back for it. Why? Because the alternative is permanent disability.
They come back because they have no other choice.
And importantly, the technique is described as simple and repeatable. It doesn't require complex microsurgery or free flaps. It can be done in more centers, democratizing access to this window of functionality. If we can give a child 10 years of cumulative hand function through 5 surgeries, is that not better than 0 years of function?
Repeatable sounds like an industrial benefit, like a repeatable manufacturing process. But clinically, it means repeatable trauma. And regarding the maintenance, the study admits that keeping those fingers apart requires nighttime splinting and constant vigilance. It turns the parents into jailers of the hand, constantly fighting the body's desire to heal shut. It is a heavy psychological burden to place on a family for a temporary lease on function. We're trapping them in a cycle of medicalization.
I agree that we need something permanent. We cannot rely on the scalpel forever. That's why the conversation has to move to the future. We have to talk about 3D bioprinting. This is where we leave maintenance behind entirely and enter the realm of tissue engineering.
Ah, the technological holy grail. The promise that we can print our way out of genetic destiny.
It is not just a promise. It's an engineering reality in development. We are talking about additive manufacturing. We take biomaterials, specifically collagen, and living cells, and we layer them to create skin replacements. But here is the key for EB. We can use this to restore the specific structural deficits. For recessive dystrophy TB, the issue is a lack of collagen 7 anchoring fibrils, the Velcro that holds the skin layers together. If we can print skin that has those anchors, we aren't just covering a wound. We are replacing the defective organ with a functional one.
I appreciate the sci-fi appeal, and I understand the mechanism. But we need a reality check. The gap between a petri dish and a patient is a canyon. And right now, bioprinting is stuck in that canyon. The source material highlights massive logistical barriers. The first is scale. EB affects the whole body. How do you manufacture enough bioprinted skin to cover the massive surface area these patients need? Current bioprinting is slow, delicate, and expensive. You just can't mass produce it yet.
Scaling is an engineering hurdle, not a physical impossibility. We solve scaling issues in every other industry. From microchips to vaccines, scaling is what humans do best.
But biology isn't just engineering. The text refers to the black box of healing. We still don't fundamentally understand the molecular signals required to activate healing in vivo. Just because you stack cells in layers doesn't mean they'll vascularize. If blood vessels don't grow into that printed skin immediately, the tissue dies. It becomes necrotic. It turns into slough. We're trying to engineer a tissue when we don't fully possess the instruction manual for how it integrates with the body.
We're writing the manual as we go. That is how medical science advances, and this connects back to the genetics we discussed at the start. You were skeptical about the KRT5 variant discovery, but that knowledge is exactly what informs the bioprinting. If we know the patient has a mutation in the 2B domain of exon 7, we know exactly which keratin filaments are unstable. That tells us we can't use their own cells without editing them first.
And that brings up the rejection nightmare. If you don't use the patient's own cells, you have to use allogeneic cells from a donor. Then you face human leukocyte antigen, HLA mismatch. You cure the skin disease, but give the patient a life of immunosuppression to prevent rejection. You trade a skin disease for an immune system disease.
Which is why the gold standard is autologous cells, the patient's own cells.
But their cells are broken. They carry the mutation. So now look at your simple printing workflow. You have to biopsy the patient, isolate the stem cells, use CRISPR or another tool to edit the KRT5 or COL7 gene, verify the edit is safe, no off-target effects, expand those cells in a lab to get billions of them, turn them into bioink, print the skin, and graft it. That is a logistical Everest. It's a brilliant theory, but for a child born with RDEB today, it is science fiction. It's not a therapy. It's a hypothesis.
It was science fiction 10 years ago. Today, it's a theoretical clinical pipeline. That is progress. We are seeing convergence. The diagnostic precision allows for the gene editing. The gene editing enables the autologous bioprinting. The bioprinting solves the recurrence issue of the surgery. It's all connected. We are moving from your skin is fragile to your helix initiation peptide is defective, let's replace it.
I want to believe in that convergence. I really do. But I can't look away from the patient in the room right now. You mentioned the KRT5 study in China again. Those patients were identified with incredible precision, next-generation sequencing, specific amino acid changes. They're the perfect candidates for this convergence. And yet they walked out of the hospital with antibiotics. The mutation spectrum is expanding rapidly. We're finding more and more variants, but the treatment spectrum is lagging years, if not decades, behind. We are dangling hope that we cannot yet fulfill.
Hope is not a passive thing. Hope is what drives the data we're seeing in the oleagial study. Reducing the EBNSC score by 16 points isn't just a number. It means a teenager might feel confident enough to leave their house. It means a mother spends 1 hour doing bandages instead of 3. That's the bridge we're building. Is it the cure? No. But is it a revolution in care compared to just Vaseline and gauze? Absolutely. And regarding the hand surgery, yes, it recurs. But ask the 46% of patients who regained autonomy if they regret the surgery. The data suggests they don't. They value the function, however fleeting.
Valuing the function because the alternative is horrific doesn't make the treatment perfect. It makes it the best of a bad situation.
And best of a bad situation is where progress starts. We are rapidly moving from palliative care, just hiding the wound, to active management with oleogel and functional restoration with surgery. The bioprinting is the next logical step.
We are nearing the end of our time, so I'll summarize my position. I respect the advancements. Oleogel S10 offers quantitative improvement in wound closure, and I acknowledge the reduction in BSAP is real. The surgical protocols for mitten hands allow for temporary autonomy, which I agree is valuable. But we must be honest with the community. These are maintenance therapies. They clean up the damage. They do not prevent the disaster. The cycle of blistering, scarring, and recurrence remains unbroken. Bioprinting faces scalability and biological rejection issues, specifically the vascularization problem, that make it a distant reality. For the patient today, the burden of care remains immense, and the treatments are temporary fixes for a permanent genetic defect.
And I see a different trajectory. We are in a period of rapid acceleration. We must not let the perfect be the enemy of the good. Having the wound surface area with birch bark extract is a fundamental shift in daily life. Restoring a hand for 2 years gives a child a window into a normal life they would otherwise never have. Combined with the precise genetic mapping of variants like KRT5 and the engineering potential of bioprinting, the path forward is clearer than ever. We're moving from understanding the disease to managing it effectively, with the tools for a cure finally coming into focus.
So it's a debate between the promise of tomorrow's science and the brutality of today's clinic.
And that is exactly where the work needs to be done. Thank you all for listening to this edition of The Debate. We hope this exchange has illuminated the complexities and the stakes of treating epidermolysis bullosa.
We encourage you to dig into the source materials yourself, look at the numbers, look at the biology, and form your own conclusions on where we stand in this fight.
Until next time.